Good afternoon, everyone. My name is Dominic Akatiba. I'm with Ghana Medical Health. Now, I want to thank you all for joining us for this afternoon's webinar on malaria and pregnancy. We are grateful to have your time today. The webinar will be recorded just like you've been prompted to, so that those who may not be able to join can be able to access it from our YouTube channel. Today, we are joined by Dr. Jonathan Zumakwe, and he is going to lead us in the presentation. Dr. Jonathan is no new person to our platform. He's done lots of legendary presentations. He's been with us in our BLS, ACLS trainings, and he's an ambassador for our NGO. So we are grateful to have him doing a presentation today for us. So participants, kindly join me in welcoming Dr. Jonathan. Dr. Jonathan, please, you can unmute your microphone and then go ahead. Thank you.
All right. Thank you very much, Dr. Dominic, for the introduction. I believe everyone can hear me.
Yes, we can hear you loud and clear.
All right. Thank you so much for the opportunity once again. As introduced, I am Dr. Jonathan Zumakwe. And yes, I've actually presented before, and I've been taking part in most of the organized activities by Ghana Medical Health. It's very informative and it is very supportive, especially for those of us in the district hospitals. I would want to say a very big thank you to Dr. Dominic for giving me this opportunity once more to share my thoughts on one of the known topics, but overlooked area, which is malaria and pregnancy. I mean, basically it is it's an area where we know, oh, it's just malaria and pregnancy. Let's just, sort it out. But there are certain details that we usually overlook. And that's why I decided to, do a presentation on it today. So without much ado, let's move on. This will be my outline. I usually start with the references because as we go on, you can, if you have the opportunity to have those books or information around, whatever I say, you can always cross-check. And then at the end of the presentation, if you have any corrections, you can bring it forward for us to all learn. It's a learning platform for everyone. So I'll start with my references, introduction, epidemiology, etiology, transmission and life cycle, the clinical presentation, investigations, and usually treatment. There is supposed to be chemoprevention as a part of it, but I'm sure it didn't show, but let's move on. So the references, majority of my information comes from the WHO guidelines on malaria 2023, and then the National Malaria Elimination Program, Ghana, the CAT guidelines on obstetric and gynecology, second edition, up to date. I took something small from up to date. And then there was a research that was done at Ejisu Hospital. It's on PubMed. You can actually read, give it a good read in 2023 on prevalence of malaria in pregnant women. And it's also a very informative research that was actually done. So that's the link. You can actually, if you click on it, once you get the slides and you click on it, it takes you directly to that particular research. So by way of introduction, pregnant women are actually very more susceptible than the general population to malaria, owing to the fact that, first of all, they are females, and females, we all know, attract more mosquitoes than we, the men, because of their pheromones. And it's a double whammy when they become pregnant because technically they are a little bit more immunocompromised than the normal person. I mean, than the non-pregnant person walking around. So they are actually more prone to malaria infection than the non-pregnant person. So, and also the presence of the plasmodial parasites in a pregnant woman's body will have a negative impact in both the woman and then the child as well. And pregnancy places a woman at risk for increased frequency and severity of malarial episodes. We'll find out all of those things later on. And as we all know, malaria is endemic in Ghana, and the entire population is at risk. But according to the National Malaria Elimination Program, the high risk children are usually those under 5 years, and the high risk group, sorry, are those under 5 years, children, and the pregnant women, those with comorbidities as well. So, of course, comorbidities will prone you to immunocompromised states, and that will make you more susceptible to malaria infection more than the normal person walking around. There is a global technical strategy for malaria. It was actually made in 2015, but adopted in 2016, and the target is to finish, to get all their achievements done by 2030. It focuses more on what the morbidity and mortality, and then eventually eliminating malaria. That's a very good target they are having. They want to actually eliminate malaria in Africa, especially in Ghana. Why are we talking about malaria in pregnancy today? It can be associated with maternal anemia already, especially as we know in our districts here. Maternal anemia is actually a problem, especially at 36 weeks. Then you now have malaria complicating this. It makes it difficult. Then you have threatened abortion, intrauterine growth restriction or retardation, prematurity, neonatal and infant mortality, low birth weight. These are just a little bit of a few examples as to why it is important for us to talk about it, because it goes unnoticed. There are some of them that come around and you see these things and you are looking for the causes. The causes can just be right in front of you, and it could be malaria. So we'll do a little bit of epidemiology. An estimated 247 million cases. This is according to WHO, and that is worldwide. And out of that, 619,000 deaths globally was recorded in 2021. Then, according to the Ghana National Malaria Elimination Program, 12 million suspected cases of malaria were recorded in 2021, 41% of OPD cases, and about over 5.7 million confirmed cases in 2021 were also seen, 20% of OPD attendance. And you can see that, you can imagine the number of malaria cases we are getting at the OPD. If you go to most of the district hospitals, especially within this period, you get to realize that the number one issue at the OPD is usually malaria. In Ghana, malaria in pregnancy accounts for about 17.6% of the outpatient department attendance. This is a snippet from the research that was done at Ejisu government hospital. Now, if you have 41% of the cases being due to malaria, out of that you have 17.6% being in pregnant women, then you know that that's a very huge number and it's a cause for concern. Global estimates indicate that in 2020, about 121.9 million pregnancies were threatened by malaria infection in endemic areas. Ghana is one of the endemic areas. In 2018, Sub-Saharan Africa recorded about 11 million malaria infections in pregnant women. These are huge numbers. And out of that, West Africa alone recorded about 6.5 million cases of malaria in pregnancy. And that's the highest prevalence of exposure to malaria infection recorded in the WHO African region in 2021. So as you can see, it is not easy. When we talk about the prevalence, it's actually very, 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 very bad, very bad. So the etiology, of course, is caused by the parasite Plasmodium, and there are about 5 species, but only one is not in Ghana yet. The Knowlesi is not yet identified in Ghana. But the stubborn 4 are already in Ghana. The falciparum is
Dr. Jonathan, I think your sound may have gone off. If you can uh, check on it again, you are unmuted, but we seem not to hear you. Hello, Dr. Jonathan, can you hear me? Hello. I'll try muting you so that you unmute again and see if that works. Maybe if you can stop sharing the screen and then try sharing again, because it doesn't, or you log out and log in again. Let's see if that works. Sorry, I think we're having difficulties with Dr. Jonathan's connection. Once it gets sorted, you continue. So apologies, everyone. We're trying to get Dr. Jonathan back so that then the presentation can continue. Thank you.
Hello, my apologies for I didn't know you guys couldn't hear me. I'm really sorry about that. Welcome to the village. I'm really sorry. So I don't know um I don't know where you couldn't hear up to.
Yeah, so maybe if you can share your screen, I would I think I also had an internet interruption as well at some point in time. So I'm going to allow participants to be able to unmute. So if anyone could kindly just unmute and let us know where he got to so that then we can continue from there. So anyone to volunteer, just unmute and then let us know where. I didn't get you from the epidemiology and after the epidemiology, but I don't know where other people lost
Wow.
off.
Hello.
Yeah, hi.
Yeah, he was still at the epidemiology when it went off.
Oh,
So
okay.
he was sharing the screen, but we're not hearing him.
Yeah. That's a lot. Is that also?
Yeah.
Yes.
All right.
Yes.
Okay. All right. Cool. Yeah, it happens. At least the good thing is I'll get this recorded and then you can pick up the recording, which can be edited. Yeah. So, okay, great. So maybe we can take it off from the epidemiology. Lauren, your microphone is unmuted. Were you going to say something?
Yeah, I just wanted to say that that's what the lady said.
Oh, okay, fine.
Was yes.
Great. Okay, all right. Thank you. All right, Dr. Jonathan, so over to you.
Okay. All right. Let me be sure that now you can hear me clearly before I continue.
Yeah,
Dr. Dominic.
Loud and clear.
All right. All right. Once again, I apologize. I really didn't know that was what was going on. Okay. So with the epidemiology, I was just giving a summary that there's according to WHO about 247 million cases and about 619,000 deaths were recorded in 2021 worldwide due to malaria. And also, I said, according to the Ghana Malaria Elimination Program in 2021, about 12 million suspected cases of malaria were recorded in 2021, 41% of the OPD cases. And out of the suspected cases, 5.7 million were confirmed, 20% of OPD cases. And I also was saying that in Ghana, the malaria in pregnancy accounts for about 17.6% of outpatient department attendance. And these are usually, this is from the snippet of the work that was done in the Ejuse Government Hospital. So if you're having 17.6% of the OPD cases being pregnant women out of the 41%, that's a lot of cases that you are dealing with for pregnant women. In sub-Saharan Africa, about 11 million malaria cases due to 11 million malaria infections in pregnant women were recorded. And out of that, in West Africa alone, about 6.5 million cases of malaria in pregnancy were recorded. And that is stated as the highest malaria infection recorded by the WHO in 2021. And that is very worrying. So in terms of the etiology, we all know the four stubborn ones. That is the falciparum, which is the most common amongst all of them, the malaria, and then the ovale, then the vivax. The knowlesi is still not recorded in Ghana. It hasn't been identified in Ghana yet, but the four horses have been identified in Ghana. Ovale and vivax are the dormant ones, the hepatic ones that stay in the hepatocytes, and then from time to time they flare up and they give us wahala in the hospital setting. Hello, am I still audible? Can I go on?
Yes, please.
All right, thank you. So I also said that the definitive host is the female Anopheles mosquito, and the secondary host is the human. It will be made. I mean, the reason is in the life cycle, the asexual reproduction happens in the human host. It happens in us, and then the sexual reproduction happens in the mosquito. And so because of that, the parasite cannot live without us. It cannot live, it can't just survive only inside the mosquito. It has to survive with inside us as well. So in terms of transmission and the life cycle, there are about 3 modes of transmission according to the National Malaria Elimination Program. You see, I have, apart from WHO, I wanted something more that hits close to home. So that's why I use the National Malaria Elimination Program document, which is very important. There are about 3. And it's only the first one is the one we are more familiar with, which is the bite of the infected female Anopheles mosquito. Then you get it. But the other 2, which is accidental blood transfusion and or organ donation, you can get malaria through that, even via mother to child during pregnancy or when they are giving birth. If the mother is infected, any opportunity that will make the maternal blood and the fetal blood to mix, you will definitely risk the child, I mean the baby of getting malaria. The second point is also a very common point, blood donation, where as clinicians we should keep an eye on, because you see that you are treating somebody something different, and then the person starts spiking temperature after transfusion most of the time. And then you think maybe you have to re-strategize, probably what your initial work plan isn't working, so you have to re-strategize, but most of the time it's always due to the blood that you transfused, because we're in an endemic area. I've seen a lot of it in practice. So as I was saying, the sexual life cycle occurs in the mosquito, asexual in the human host, and usually the incubation period is 7 to 21 days. And by way of the life cycle, the mosquito usually takes a blood meal from the human host and introduces the sporozoites into the blood. These swim through the bloodstream into the liver and then enter the hepatocytes, where they start where they develop into the merozoites in the hepatocytes. They rupture, come out, into the bloodstream and then starts infecting the red blood cells again. So these merozoites infect the red blood cell. This RBC cell stage is very important in the microscope, because at that point you can actually get whether it's the ring stage, is the trophozoite stage, or is the schizont stage. So all these things, once you stain it very well, you can actually see them and you can quantify them. And that is why it's important, because in the RBC, once they develop into the ring to the trophozoite schizoids, they rupture at the schizont stage. Then they go out and infect another virgin RBC to start the whole cycle all over again. However, some of the schizons develop into the male and female gametocytes. And once the mosquito comes to take a blood meal, it takes these gametes alongside the inside, along the blood that it takes. Then it goes into these male and female gametocytes, start developing the mosquito. They fuse to form the zygote that develops into the ookinetes and then the oocyst, eventually developing into the sporozoites. And these are stored in the salivary glands of the mosquito, waiting for it to come and take another blood meal. The moment it takes the blood meal, it takes the blood and replaces and then gives you a gift as well. The sporozoites from the salivary glands into the human host, and the cycle just keeps on going and going. And so that's why, like I said, it cannot survive without us, and it can also survive without the mosquito as well. So how do people with malaria present? According to WHO, it's split into two. I hope I'm still audible, please.
Yes, you are.
Yes.
All right, thank you. So it's split into two: uncomplicated malaria and then severe malaria. And the uncomplicated malaria is the one that has no signs of severe disease. Of course, you have to have fever, confirmed either RDT or microscopy that has been done to confirm that you have a malaria parasite in you. But then there are no signs of severe disease and no vital organ dysfunction as well. Once you see these things, it means that the person doesn't have severe malaria. We'll get to see what the signs of severe diseases and the signs of vital organ dysfunctions are later on. Then the severe malaria is the opposite of the first one. You have the fever, signs of severe disease, signs of vital organ damage with the test, RDT or microscopy. They are acceptable. Microscopy is the gold standard, but if you don't have it and you have your RDT, you can actually use that. So these are the signs of severe disease. The person is inability to drink, is unable to drink, and vomiting every single time. Even water enters the mouth, they are vomiting. Such a patient cannot tolerate oral, so it's a severe form of the disease. Presence of convulsions, lethargy, general weakness, unconsciousness. And these are some of the signs of severe diseases. And in terms of the vital organ dysfunction, start with the brain or the CNS. Convulsions, yes. Unconsciousness, yes. Unconsciousness, which is usually the peculiar sign you see in cerebral malaria, which is defined as the unarousable coma. And you can see confusion, restlessness, lethargy. All these are CNS signs of severe disease. You'll see deep breathing, respiratory distress, or difficulty in breathing in terms of the lungs. The heart, you see signs of shock, especially in the pregnant women that has severe diseases. Shock, you see those signs there. So it's very key to always pay attention to their vitals when they come in. The liver, you see hypoglycemia and jaundice. Kidney, of course, you see reduced urine output and cola-like urine as they will present to you. In fact, it's one of the things that scares them. Once they see the cola-like urine, they're actually usually afraid. Hematological, you see severe anemia, abnormal bleeding. The severe anemia usually is less than 5 in kids and less than 7 usually in adults. This is according to WHO. Generally, you see that the person is severely dehydrated. Temperatures will be all over the place at the extremes, either hyperthermia or hypothermia. There will be prostrations and general weakness of the patient. And so these are the laboratory values that you see. Like I said, anemia, less than 5 in kids, less than 7 in adults. The hypoglycemia, as you can see, the renal impairment, you see high serum and urea levels. The jaundice you see in your serum bilirubins as well. And basically, you can even see the hyperparasitemia in terms of the microscopy when it is done. Pulmonary edema, you can see it, especially when you do a chest X-ray, okay, which is not actually recommended in pregnant women, but just is for a need-to-know basis. Now, in terms of investigations, like I said, the gold standard is the microscopy, which is usually quantitative. It will be able to quantify the number of parasites you are dealing with, and it will even tell you the stage of the parasite you're actually dealing with as well. And then if you don't have that, and then you have your RDT, you can still do that because it's usually the qualitative one. It just tells you it's positive or negative, and you can still go ahead to treat the patient. So the treatment, how is it done? There are some major changes, and this is where like I said early on, that usually the reasons why malaria in pregnancy is important is usually the chemo prevention and then the treatment usually, because initially there were studies that said that we should not use the artesunate in the first trimester because of that it had some teratogenic effects in the fetus at that time during the first trimester. So we're limited to just using it at the second and third, and we're asked to use quinine for the first trimester. We'll get to these things later on, but I just wanted to the three major changes, some of the major changes that are there. We have moved away from the chloroquine long time ago to the ACTs, the artemisinin-based combination therapies. Then the change from the quinine to the IV artesunates for severe malaria management, like I was saying early on, and from the presumptive treatment to the 3T policy: test, treat, and track. And this is actually very important because mostly initially it was just pure microscopy, but now RGTs are everywhere. You can actually get it at every corner, so which is very good, so that this 3Ts policy can actually work. So what are the principles of treatment? So we have you have to give the specific anti-malarial agent, supportive care, because usually when they come with some symptoms and signs. So you have to also do symptomatic management as well, alongside giving the proper dose and choice of anti-malaria you are giving. Then you counsel, and then you follow up to see whether the person is doing well or not, because there have been recorded cases of treatment failures as well. So in uncomplicated malaria in pregnancy, the whether first trimester or second trimester or third trimester, you can use your AL, artemether lumefantrine, or artesunate amodiaquine. You can do that. You can use it. And so you can use them. The only one you are not allowed to use is the AP, the artesunate pyronaridine. You are not supposed to use that one. See, and that one too is still the same issue they had with the AL initially, when they said you can't use it in the first trimester, because they still don't, or they also have studies that shows that it's also, having some teratogenic effects, and they don't actually do. Secondly, they don't have a lot of studies on it as well, so it's not allowed. Quinine, clindamycin can also be used. If you check, there is nothing like primaquine here as well. It's also allowed. The primaquine, when you are using it for the stubborn ones, that is the Ovale and then the Vivax. But if you are to use, that's what we use for that. But in pregnancy, you can't use the primaquine like that. It's not, so as you can see, it's not part of the list that we are actually using for reasons that we all know. And the reason why they actually even switched to the artesunate and then the artemether lumefantrine is because, you see, one, quinine has its own issues. It can give you synchronism. It's one of the common side effects of quinine. And it can also give you hypoglycemia. So in pregnant women, these are actually very bad things to be given. I mean, these are very bad side effects. And what is, the most common of all of it is that quinine was just not very. We were not using it. It wasn't readily available for us to use as we really wanted to. So they realized that for malaria to be tackled very well, you have to use the ones that people tolerate. Pregnant women can tolerate it. Everyone else can tolerate it, and it's readily available with less side effects, so that it's safe for people to take. And so that was why they reverted back to us using it across all trimesters. So, like I said, artesunate amodiaquine, artemether lumefantrine, dihydroartemisinin, piperaquine, and then quinine clindamycin. In terms of severe malaria, all patients must be admitted for parenteral treatment, and it must be given at least 24 hours. You know, when they come in, you say admit and give at 0, 12, 24 hours with the ACTs. And once the person is able to now tolerate oral, once the severe has been transformed to uncomplicated, you can now continue with the 3 days dosage of the oral medications. And this is the same thing we do for the non-pregnant people as well. But the reason why we are mentioning it today is because of the fact that, like I said, we all know that once upon a time, quinine was we should be using that in the first trimester. Now we no longer use that at. I mean, AL across all boards is acceptable, and this is the preferred order of anti-malarials when they come. So IV artesunate all trimesters. IM artesunate is also allowed all trimesters. IM artemether second, third trimesters, and piperium. Again, artemether is also the same thing they said about artesunate. So you see that second trimesters alone. Let's take note of that. IM artesunate. The quinine, IV quinine, and IM quinine, IV quinine infusion, all trimesters is still allowed. It's not like we've cancelled it. It's still allowed if you have it and you can use it. It's all okay. Yes. So that's just by way of the treatment in terms of malaria in pregnancy. Then we move on to what are some of the complications malaria can give you. Maternal complications usually include severe anemia, like we said earlier on, hypoglycemia, cerebral malaria, renal failure, hepatic failure, hypotension, acute pulmonary edema. We mentioned all these things early on, and disseminated intravascular coagulation, which we did not mention early on. So it's good that it came up. And then we have the fetal complications, where you can have a spontaneous abortion, premature delivery, which is very, very common because they come in. We just delivered one, I think, last week, 36. The person was 36 weeks, came in with severe malaria. Temperature was skyrocketing. Before we could say that, she was already 5 cm dilated. We're treating and she was already contracting. So she delivered anyway, but and baby was of normal weight. So that was lucky for us and for her. But malaria can actually trigger a lot of premature contractions quickly. And usually, if you don't treat it well early enough, this thing, premature delivery can happen. Intrauterine growth restriction, and then intrauterine fetal death, unexplained fetal death. This is not only hypertension in pregnancy that can cause that. Malaria too can also, lead to that as well. Then in terms of chemo prevention in the pregnant women, we will go to what we use according what we already know in terms of WHO recommendations. It says, like in malaria endemic areas, the pregnant women of all gravidities should be given anti-malaria medicine at predetermined intervals to reduce the disease burden in the pregnancy and adverse pregnancy and birth outcomes. This is just to summarize. I mean, in summary, just saying like at all levels, especially Ghana is an endemic area, and I know that a lot of us, the intermittent preventive treatment that we give, the IPTPs that we give at the ANC is very important. We do that, and then still they come with the malaria. So it means that we are preventing. Does not mean that it cannot still happen. And this is something that should be adhered to. The SP has been widely used for malaria chemoprevention during pregnancy, and it remains an effective way of improving key pregnancy outcomes. It should start as early as possible in the second trimester. As early as possible in the second trimester, and not before 13 weeks of pregnancy. Again, due to the side effects of sulfur, because of sulfur-based medicines, the side effects it can give us. That's why, like I said, the teratogenic effects is one of them. So that's why they preferred that it be given in the second trimester onwards, just like the artemether I was talking about. So the doses should be given at least 1 month apart, with the objective of ensuring that at least 3 doses are received. You can from 1 month apart, meaning that from your second trimester you can get as many as possible. But WHO recommends that if it's not possible, at least let the person get at least 3 of them before they actually give birth. It will help the patient. And antenatal care contacts remain an important platform for delivering these drugs. Now, where inequities in ANC service and reach exist, meaning if you cannot reach an ANC service area, other delivery methods such as the use of the community health workers that we have in our communities here may be explored, using that ANC attendance is, ensuring that the ANC attendance is maintained and that line inequities in the ANC delivery are addressed. So technically speaking, if they cannot come to the ANC, the community volunteers, the CHOs, and then the what's the name? All the community health nurses we have can all come in to support in delivering these medications to the pregnant women. Like I said early on, it doesn't go on to actually completely protect the pregnant woman. They can still get it, but it goes a long way to actually reduce the frequencies of their visits to the hospitals. Which is, I mean, if we are in practice, if you notice that those that actually do take these drugs don't usually show up frequently as compared to those that usually don't take them, especially those that are in the peripheries. IPTP is generally highly cost effective. It is widely accepted and is feasible for delivery and justified by a large body of evidence generated over several decades. So it's not like somebody just sat somewhere and say, do it. It was due to research that has gone into it for years and years to come. And that is why till today, it's still a mainstay as the the main choice for any chemopreventive drug for all the pregnant women that we have. So this is just a quick lecture I had, and I thank you all for your audience, and I'm grateful for the opportunity, and apologize once again for the interruption whilst we're going on with the lecture. Thank you.
Excellent. Thank you so much, Dr. Jonathan, for an excellent job done. It's been insightful, it's been great. But for the network that delayed us a bit, but we're still able to still finish off before the hour mark. So we have some minutes for questions, for comments, for additions, and for contributions. So kindly electronically raise up your hand and I would unmute you to talk if you have any question. Yes, Stella, please go ahead. I've asked you to unmute.
Hello, good evening. Can you hear me?
Yes, please.
Yes.
Please, I want to know those neonates that will be delivered preterm due to severe malaria. Are we supposed to test them for malaria or wait to see the signs and symptoms before we treat them for malaria?
Okay. Yes. No, please. You don't go ahead to test them for malaria. Like I said, one of the sure ways of actually getting malaria, especially neonatal malaria, is through birth, especially in a woman with severe malaria. But if the baby is not showing the signs, please let's not go ahead. You can do that if you just want to rule it out, but the baby will have to show the signs first before you actually go ahead to test to see if there is a malaria in the baby. I don't know if I've answered you.
Great. So any other question again, please put up your hand. Question, contribution, comments. Don't feel shy. Yes, put up. Yeah. So Laurentia, please go ahead.
Okay, good evening. Please, I'm working at the health center. We have instances where a pregnant woman comes and then you test, then she's positive. Then you give her the treatment and she's like, my baby doesn't, it's not active all the time. She's suspecting that because she has malaria, the baby is likely to also have malaria. Are we to test the baby just like she asked? And again, the second one is, when the woman takes the malaria treatment, can the malaria pass through the breast milk to the baby? The drug, the anti-malaria, can it pass through breast milk to the baby? Thank you.
Okay. So the first question, no, you're in the pupurium. If the woman comes and is saying is afraid the baby will also have malaria, we've talked about the three modes of transmission: through mosquito bites, through blood transfusion, and through maternal during birth or even in utero. So if it's in the pupurium and the mother comes malaria positive, if the child is not showing any signs of it, it doesn't mean that the mother cannot transfer the malaria to the baby just like that. Except these three ways, you can actually get the malaria. So when they come, use these three modes to know that the mother is safe for treatment. And in the breast milk, there is no evidence that show that there are significant quantities of the drugs that enter the breast milk in any shape or form. So it's actually okay to still treat them. The child will be safe from that as well. Okay.
Great. Marian, please go ahead. Okay. Whilst we wait for Marian, Lucy, please go ahead.
Okay, thank you very much. It's such a wonderful presentation. My question is, sometimes you have a client who actually exhibits the symptoms of the malaria that you shared, but then you do the test and it's still no MPs. So in this case, do you treat the person as uncomplicated malaria with the treatment mentioned? Thank you.
Please no. Like I said, we've gone from the guessing and treating point years ago to the 3 T's. You test, you treat, and then what's the third one?
You track.
You track. Yes, you test, you treat, and you track. So please, if they come and it tells you no MPC, it means that it's something else. And we have various forms of infection in the body, and our body shows nearly similar signs and symptoms. So the person could be suffering from simple UTI, and you don't know, especially in the pregnant women, it's very common amongst them. Okay, so you would have to go further and investigate somewhere else. If it is not positive, if RDT is not positive, and microscopy is not showing malaria, please don't treat. Look for something else in the woman. Thank you.
Great. So, Marion, please unmute yourself and go ahead.
Okay, thank you. Please, mine is on the chemotherapy, the IPT. It's a little bit of clarification here with the contraindication to taking it.
Okay.
If a pregnant woman is Hep positive, is she allowed to take IPT or she's not allowed to take? That's where my clarification wants to be. Thank you.
Okay. So I get where your question is coming from, because even we also said that any woman with G6PD deficiency is not allowed to take chloroquine, primaquine, those things, and then some of the sulfur drugs. But apart from that, if you are Hep B positive, there is no, so apart from these things I've mentioned, if you are Hep B positive, you can actually take it. The sulfur drugs that, like I said, if you are talking about the effects on the baby, it's because of the teratogenic effects. If you are talking about the effects on the man, the woman, it's actually with the dosage that is being given. The Hep B, unless it is actually active and it's actively replicating and it's actually giving you signs and symptoms, then you may consider not giving. But if it is one of the dormant strains or you're actually under treatment, then you can actually take SP.
Great. Laurentia, please go ahead.
Yes, my question is on the RDT for malaria test kits. I want to know whether the RDTs that we use to test the malaria, is it able to determine the type of falciparum that we have, or is just the is it able to test all of them, so that when you test and it is the ovale, it will tell you. If not, it means that sometimes you may test and then ovale is not detected and it will tell you that the woman is not positive to malaria. And then you think that she's not positive, then you go and treat for other ones. Meanwhile, she's actually positive to that type of this parasite that you have, the malaria parasite. So I don't know whether it can determine that. Thank you.
Well, no, it cannot. The only one that can do that is the microscopy. Like I said early on, the RDT is just qualitative. It doesn't quantify it. It doesn't also identify the species. It just tells you whether it's positive or it's negative. So whether it is ovale, whether it's vivax, whether it's falciparum, it is, and as long as it's in you, it can detect it and to tell you whether it's positive or negative. If you test and you don't get it, you do RDT. However, if you do the RDT and it's negative, you can go ahead and do the microscopy to confirm your RDT. You get what I mean? And that is the one that can actually give you the stage, the species, and then usually the quantity of parasites you're actually dealing with. If maybe at the community level, you do the RDT and it's negative. You can always, and you are very, very sure that this is malaria. You are not giving up on your suspicion. You can always refer to the higher centers with the microscopy to actually confirm it, please, before you start treatment. The reason why we are doing the treaties is that, you see, back in the reason why even the ACTs came into being was because the malaria, the chloroquine that we all knew was becoming ineffective. And the reason was that we were just issuing out chloroquine anyhow. It's just like how nowadays you come in, somebody will come with asymptomatic bacteriuria. Nothing shows that the person has UTI, but we're just, okay, carry cefuroxime and go and drink. One day we'll get to realize that that cefuroxime we are giving is not even working anymore in these pregnant women. It's the same thing the chloroquine came to be. We were just abusing it. Somebody will come, the person is not even having malaria at all. Probably it's even stress that will be giving the person these kinds of things. Nothing infectious, but we just carry chloroquine and give. So it got to a point where the chloroquine was no longer effective. And also it was no longer effective because it will stay so long in the system, in the human system. So the malaria parasite had time to actually adapt to it. So that's why right now we're actually being careful and advocating that if you don't see it being positive, just don't treat. Look for other investigations. There are 1,001 infections that will mimic malaria. I can tell you that. So in summary, RDT cannot detect whether it is the species for you. It cannot quantify it for you. It can just tell you whether it's positive or it's negative. If you want the quantity, or if which one it is, or the stage that you are looking for, you have to do the microscopy for that. Thank you.
All right, great. I don't see any hand up. If you have any question, I'm happy to unmute you. Huru, you said you wanted to put a comment and you could not. So I've asked you to unmute and then ask your question. Munira to Huru. Please go ahead. Please feel free to ask. Otherwise, then we can draw the curtains down on today's presentation. Okay, Dr. Jonathan, it looks like we don't have any other question. I see a question in the chat box from Stella. She's asking about G6PD deficiency. So for those patients who are G6PD deficient and the chemoprophylaxis, the sulfadoxine pyrimethamine cannot be given to them, what anti-malaria prophylaxis can be given in this place?
Yes, with those ones that are like that. You see, there is a new. I didn't want to add this because it's not something that we haven't, as a country, adopted it as of yet. But it is something that is still in the pipeline, wherein we can still, as because we are endemic, we can also still use the 3-day course of the malaria treatment at least every 3 to 6 months, even if you are not having malaria. It's like also a form of chemo prevention. But it's true that it's a very serious case. You have to weigh the benefits against the risks. Like I said, piperaquine, sulfur drugs are not very good. I mean, you shouldn't be using them like that in GCPD deficient patients because it will give them jaundice. It will accelerate. It will worsen their anemia and whatnot. So for them, like I said, they are left alone. But like I said, in my setting, what I do is that I give them the 3-day course of anti-malaria, the AL. and then they go for that. And they're actually well protected from it as well, and it helps them. So, but I don't do it the monthly basis, because the one I recommended by WHO is usually the SP. So it's a very dicey, it's a very good question. I expected that, but I didn't hear anybody ask it. But thank you for asking. We leave them alone. That's what I would say. But in my setting, I try, because here it's very difficult to actually not protect them. So that's what I do. I give the AL.
Great. Just to add as well, the GSSPD deficiency, you have the full defect, the partial defect, and all of that. So really,
Yes.
like Dr. Jonathan rightly said, usually we weigh the benefits versus the hazards, or the risk versus the benefits, and then decide appropriately. So there are actually a couple of them who are still put on the SP, but that is under strict clinical supervision, so that then if you start hemolyzing, we can typically
withdraw it.
stop it.
Yes.
But the rule of thumb, like Dr. Jonathan mentioned, is that we don't give them the SP routinely, but you ensure the strict mosquito bite prevention, like you mentioned, Stella. And then as well, one key thing that we usually recommend for the gynecologist or you, the midwives in the rural setting, is that you, like Dr. Jonathan mentioned, the 3Ts. For those guys, immediately they come with a fever, you would want to do an early testing and early treatment, so that then it doesn't run into complications, since they are not on the SP for the intermittent prevention. Great. I think that's all for now. We just want to say a big thank you again to you, Dr. Jonathan, for an excellent job done. This has been very educative. Lots of people have learned. I'll bet the network drop-off, we're still able to do it in about an hour. So we are grateful, and we've all learned, and we say God bless you. And I wish to also thank all the participants who made some time. We had on the average about 65 people joining in. And so we are grateful that you joined us for today. Look out on our platforms for the other webinars that will be coming up as well. Have a blessed day, and God bless all of us. Bye-bye.